We are live now, doctor.
Yeah. Very good evening, everyone. And on the behalf of Rajasthan Ophthalmological Society, I welcome you to this webinar on demystifying the neuro-ophthalmic visual fields with an intent to localize the lesions. And that's a very important part. We all know that it's very important to learn in the ophthalmology, especially in the residency. So today we have Dr. Meenakshi Dhar as a uh, speaker here. She is a professor and head of Amrita Hospital, Amrita School of Medicine in Faridabad. She has a keen interest in neuro-ophthalmology, glaucoma, pediatric ophthalmology, and she's also a prolific cataract surgeon. So she's a pan-ophthalmologist in a way, I can say. She has a specific interest in the OCT, visual fields, multiple sclerosis, drug-induced optic neuropathy, and idiopathic intracranial hypertension. She's a postgraduate teacher for about 20 years in the Amrita Institute at the Cochin. She has received many honors by AIOS, WOS, and EOC. She is a graduate and postgraduate from Maulana Azad Medical College, Delhi. She also did a clinical observership in Jules Steen Eye Center in UCLA, California. And she has presented more than 200 presentations and in various national and international fora, has more than 30 publications to her credit. She has won AIOS Travel Trainee Fellowship in 1994, Best Poster for Glaucoma in AIOS in 2019, and she's also a member of INOS since its inception. Along with this, she's also a member of AIOS, GSI, and WOS. So we also have Dr. Rishi Mehta as the moderator for this session. Dr. Rishi Mehta is a professor and head of the department at the Geetanjali Medical College. And we have got two residents, Geetika and Hot Seat, Geetika and Mani on the hot seat. And the pattern of this Kaksha is like that we have a couple of residents on the hot seat and the moderator on the there with the presenter. So whenever they have a doubt or whenever they need something to be clarified or to be added, they can stop the presenter. It's more like an interactive didactic lecture. So all set to go. Welcome, Meenakshi ma'am, and thanks for accepting the invite. We go ahead and start the session now. Thank you.
My pleasure, Ankur, and thank you for those kind words. I'll do the full scale. I'm sharing the screen now.
Yes,
Now
ma'am.
I'll just go to the full mode. Once. Is this visible?
Yes, ma'am. Absolutely.
Yeah. Thank you. It is my pleasure and honor to be a part of the Kaksha series. And I must say it's a beautiful, wonderful concept. I told our postgraduates also to join in. So as far as neuro-ophthalmic fields go, we know that this is a very important part of the examination and evaluation of any patient who comes with a neuro-ophthalmological problem. We know that what are the extents of the normal fields in different directions, uniocularly and binocularly. And then, so we have to first think of why and when will we do a field when we are having a patient of neuroophthalmia. So if a lesion involves the visual pathway or we are suspecting that, we should do it. As a part of a complete neuro-ophthalmological evaluation, we should always do it. It helps us in localizing depending on various patterns. It's an excellent tool to follow, to use when we are monitoring either the progression, the resolution, or recurrence of a disease. And it helps us in guiding the treatment in diseases like intracranial hypertension, the optic neuropathy, whether otherwise or whether toxic or with multiple sclerosis, in patients of pituitary adenoma and in other cellular lesions. It can be used as a screening tool for toxic optic neuropathy, especially like ethambutol, vigarobatin, or linezolid in the current times. And also sometimes it can help us in seeing as to how much a patient's activities of daily living are getting affected. So when we are thinking of doing it, we know that a confrontation method will pick up 20% of the arcuate defects. It will pick up 70% of the hemianopic defects. If a patient is confined to bed and is sick, This is something, but is conscious. Naturally, we can only do it in conscious and cooperative patients. We can get some idea, even though they may not be able to reach one of the methods of examination like the kinetic perimetry, which is very good, but it is not really practically done, and in most places it's not available. So we fall back on the standard automated perimetry, where the Humphrey is the standard one which is used, and it could we can use either the 24-2 or 30-2, and whenever we feel that we need to see what is happening in the peripheral field, we can do a 60-4. FDD, if we do it, it picks up an optic neuropathy, but it cannot diagnose hemianopias. And patients of optic neuritis, yeah.
What is the advantage of a red target over white target in this kind of visual fields?
So see, normally the kinetic perimetry is not done these days, but the chances are that the red target will be picked up more often than a white target. That's why it can be done, but you can see that there is a lack of how many places have a kinetic perimetry now. Shall I go ahead?
Yeah, sure.
Optic neuritis patients show significant variability of threshold measurements between consecutive tests. So practically each time when they complain of a decrease in vision, they need to undergo a visual field test to see as to what is happening. So whenever and sometimes the central field may come normal, but you are suspecting something. So it's a good idea to do a 60-4 as well, so that we do not miss a peripheral loss. So we diagnose a neuro-ophthalmological field because it respects the vertical midline. It originates from the blind spot because the nerve bundle is involved. If it is a pre-chiasmal, if it is a chiasmal lesion, then it is a bitemporal lesion. And in post-chiasmal lesion, it comes from the macula. It respects the vertical midline again. And one can differentiate it from a glaucomatous field defect, because glaucomatous field defects generally honor the horizontal meridian. They are central pathology, visual field defects or scotomas are very late in the day. More often, it's arcuate. In comparison, the thing which can happen in a neurological field defect is an altitudinal defect. We generally, in glaucoma, it is the nasal half which is involved earlier, or you may see a Roney's step. While coming back to the neurological field defect, as we said earlier, it respects the vertical meridian. It could be central or paracentral, altitudinal. Nasal half is rarely involved except in some cases of IIH. So there could be a lot of overlap. So one has to take it along with the other findings, whether it be it clinical, the history, the OCT, and the imaging, and then come to a diagnosis. So the first and foremost thing is, whenever you are evaluating any visual field, place the right one on the right and the left one on the left as the observer would see it. So always put the fields like this and then try to assess and see if there is a pattern which emerges or where the other visual field loss. So we know that the optic nerve pathway and it has very distinctive steps as to what will be the field effect where the different parts of the pathway are involved. So if it is the optic nerve which is involved, more likely on one side there may be affection, which may be from central to centrocecal, or it could, when it is chiasma, generally it's a bitemporal field effect. When it reaches the optic tract, if the optic tract is involved, it could be an incongruous homonymous hemianopia. So either the right half of the field is gone or the left half of the field is gone. When the lesion is in the lateral geniculate body, you can have a homonymous sectranopia, where if it is the lateral geniculate body which is involved. So if it is a lateral geniculate body which is involved, it will be a right homonymous sectronopia. So that means on the contralateral side. If it is a left temporal lobe involvement, because the fibers which are involved are the inferior fibers, it is going to have a field loss in the superior aspect. And here we have the Mayer's loop also, which I'll be talking about, because the inferior fibers, they take a bend, and then the inferior fibers are compressed first. So you get what we call as pie in the sky. And if you don't see it and if you're suspecting and then you don't see it in the central fields, you can do a peripheral field and you may be able to pick up. On the other hand, if it is a parietal lobe which is involved, then here the superior fibers are compressed, and the contralateral side you have a defect which is more in the inferior half. Because after this, the field defects become more congruous, so when it reaches the occipital lobe, if it's the upper bank which is involved, you can have a macular sparing and a homonymous lower quadrantenopia, or you can have an upper quadrantenopia homonymous again with macular sparing when the lower bank is involved. When the right occipital lobe is involved, there will be a left the opposite side homonymous hemianopia with a macular sparing. As you can see in all these fields, it respects the vertical midline. So coming to optic neuritis, you generally, if it is the same side, will have a unilateral field defect, which may be mild or severe. It may be diffuse or focal. It could also be paracentral. It could also involve the periphery. It could be centrocecal, that is extending between the blind spot and fixation, especially seen when there is a neuroretinitis involving the papillomacular bundle. It could also present as an arcuate nerve fiber bundle defect. And one has to remember, like in this patient, you can see that at different times when he came, the visual fields have a different picture, and so they are not static. In multiple sclerosis, 100% of the patients, there will be a field defect, and in the affected eye. And in the fellow eye also, you may be able to pick up a field defect. It improves on follow-up, and there is a 15 decibel loss, which can correlate with a moderate to severe loss. In multiple sclerosis, the type of defect which can be there, it could be the most common is diffuse, or it could be centrocecal, or it could be altitudinal, it could be even arcuate, and very, very rarely it could be even a hemianopic. So this is one of our patients who had, yes?
In case of the visual field defect of optic neuritis, after how much time of the onset of optic neuritis will the visual field defect will be evident? Is there some like
a field defect when there is visual affection? If the vision decreases, there will be a field defect simultaneously, but changes on OCT will appear only later. Visual field defect correlates with the visual loss. So it will occur immediately or at the same time, simultaneously. I hope that answers my question. Yeah. So coming to, like here, this is one of our patients who had affection of both the eyes. The left eye was basically is what the patient presented with. Right eye, he had 6/9 vision. But you can see there are field defects in that eye area also, in that eye also. Sometimes these multiple sclerosis patients come again and again with repetitive attacks. And the field effects from an earlier attack may not have gone away. It's just that actually when I'm now in North India since 2020, I have seen less of MS, maybe because for whatever reason. But while I was in Cochin, I did see a lot of MS there, and in contrast to what is believed that in India we don't really have MS. Maybe that was a referral center there or whatever. So, but you do see these patients. So sometimes you treat a patient as optic neuritis, the way they seem to have features, but then when you end up doing imaging, you find that it is, like in this case, it was a tentorial meningioma. So, so we have to ensure that our the imaging is done, two, the imaging is correctly interpreted. Even an anterior ischemic optic neuropathy presents with an altitudinal field defect, very rarely arcuate central or quadrantic. These defects are stable, they improve, and they rarely worsen. But and they very often they do not improve. That's the sad part of AION. And then coming to IIH, here what we have classically been told is there is an enlarged blind spot, there is constriction of field loss, and there is inferior nasal field losses more often. These patients also have a waxing, waning, sometimes affection. They present with the problem. There may be some patients who may have no field defects, but it is important to document that, and they may have changes on clinical examination as well as on OCT. But when we follow up these patients, they may end up coming at a later stage with the field defects. And as treatment is started, they do improve. So getting for us, maybe at generally at 1 to 3 months, we call them for a follow-up, or unless if they present with a newer problem of visual loss, then we again do the fields for these patients. So the thing with intracranial tension is that this is something which is holocranial. Different parts of the brain may be involved, and it presents as visual field defects, which could be of a varying part depending on what is causing the field defect. Is it the optic nerve, the papilledema, which is causing it? Then it will be an enlarged blind spot or visual field constriction. If it is the dilated third ventricle which is causing the field defect, then it could even be a bitemporal field defect. If it is the optic tract which is getting affected because the shunt, which is the shunt catheter is passing through it, or there is a dilated ventricle, or it could be due to a mass defect. Patients can have incongruous defects, and it could be also along with a relative afferent pupillary defect in the eye ipsilateral to the field defect. Or when the optic radiation could be involved, either because of ischemic changes or because the shunt catheter is passing through the parietal lobe, you can have a homonymous inferior quadrantic defect. If it is the occipital lobe which is involved either because of ischemia or because of the posterior cerebral artery occlusion, or the shunt is impinging on the posterior cerebral artery, you can have homonymous defects with macular sparing. Or it could be a compression of the occipital lobe by enlarged ventricles or bilateral infarction of occipital lobes, and it will end up being a bilateral superior or inferior altitudinal defect. So there could be a plethora of field defects in patients with IIH. And we know that patients with papilledema doesn't necessarily have to be just IIH. It could also be glioma, which is causing an extensive papilledema and with enlarged blind spot. And there could be also a disc coloboma, where there could be a field defect, which is like a superior altitudinal defect. And here there would be maybe a large enlarged blind spot also. But one has to remember, this defect will be superior. On the clinical examination, you will be able to see the coloboma, and this defect is static. It does not change because the pathology is something which is inborn and it's not going to change. Then the drugs, whether it is ethambutol toxicity or HCQ, they cause a central scotoma, and in vigabatrin, you can have peripheral constriction. These days, linezolid, which is being used, they can have centrocecal defects. Now, patients who are put on ATT, we should encourage the clinicians that they should have a baseline evaluation. It becomes all the more important because at baseline itself, a patient may have the field defects, which could be not, and they should later not be confused that it is being caused by the disease. Like in this patient of ours who had a tuberculoma. So these field defects were already present at the time that the ATT was being started. And as I already mentioned about linezolid toxicity. So we, like, for instance, it is always a dilemma, and you are always the Sherlock Holmes sometimes to try and find out what is causing it. Like this patient, a doctor, an ophthalmologist who came to us from Africa, he had a marked visual loss in his left eye, and he had this field defect, which you can see is more in the temporal half of the right field. It's like a temporal quadrantenopia. And he was being treated as glaucoma, and he did have a high IOP also at some point of time. Our PI was also done. So there you can see this temporal wedge-shaped defect, including the blind spot, and it is respecting the vertical midline. When we did the peripheral field defects were not really contributory, and when we saw the if you look at carefully at the NRR rim, one can see that there's a slight pallor on the of the rim. And when we did the MRI, we found that there was a huge pituitary macroadenoma, and this was compressing and causing the problem. And in this patient, probably it was a post-fixed chiasma, which led to the effect of the pituitary adenoma being only on one optic nerve. And as we know that out of the 10% of chiasmas could be either prefixed or post-fixed. And it is 80% of chiasma which directly lie over the sella. So you can have affection of either the optic nerve or the optic tract with a tumor which is in the sella. And although classically what we say is the biotemporal hemianopia, this is an oversimplification. If you assess, say, 100 of patients with pituitary tumors, it will be only in very few that you will find this classical description. More often it is asymmetric, or it could be involving only one quadrant, or it will be involving one quadrant in one eye and 3 quadrants in the other eye. It depends on what is the size of the lesion, how it is affecting the chiasma. So it could be quadrantic or hemianopic as well, complete or incomplete, superior or inferior, absolute or relative, peripheral or central combination. There could be a splitting of macula, and it is progressive unless there is a treatment. And in this regard, it is the OCT which helps us in saying what are the chances that there will be a reversal. So if your OCT is showing no thinning on the RNFL and you have severe field defects, once the surgery is done, the chances of the visual recovery is higher. While if the thinning has already occurred, the chances of recovery are less. So in this patient, you have on the right side, you have a temporal hemianopia, but on the left side, you have not only a temporal hemianopia, you have a left eye inferior quadrantenopia. And in this patient, where again, it was like I said, I showed that case, since it is a post-fixed one optic nerve is getting more affected and the other one is normal. Then there is this concept of junctional syndrome, which is because there are few fibers which come, the nasal fibers, which go into the other optic nerve, and this is called the Wilbrand's knee. And here you have an ipsilateral visual loss, and on the contralateral nasal fibers are affected, leading to a isolated superior temporal field defect. Also, along with this, you have color vision defect, you have RAPD, you have optic atrophy. So this is something which can be very interesting to observe when we have a look at the fields of a patient, which will tell us as to where is the involvement. Then you can, so this is the patient. Most of the field defects that I have shown till now are all of my patients. But this is a book picture where you can see that there has been a junctional syndrome. When since the pituitary is something which lies below the chiasma, the defects which occur because of pituitary adenomas are more in the upper quadrant first. So in the right eye, it follows a clockwise pattern, while in the left eye, it follows a anti-clockwise pattern. And so like here you have a you can see that where in contrast, if it is a craniopharyngioma, which gives a pressure on the chiasma from above, or a pineal germinoma, you have the lower quadrant is involved first in both the temporal halves. So you have right inferior quadrantenopia and left inferior quadrantenopia. Here, the field effect seems to progress in the right eye in the anti-clockwise direction and in the left eye in the clockwise direction. So it can be interesting to see these patients. The thing with the chiasma, the craniopharyngioma occurs in children, and they may or may not be able to cooperate with you for fields. But it is surprising to see that sometimes even 10-year-olds come out with very good fields. And this is something which you, as you know, the history of the disease is that there is a waxing waning thing. So when we do the surgery, then the patient maybe after a year and a half may again come with a visual problem. Again, you do the fields, then you ask for an MRI, the thing has reoccurred. So this can happen many a times. In this patient, this was like a prefix chiasm. So there is more of an affection of one optic tract, and you can see that the left hemianopia kind of picture is there. Then there are sometimes chiasmal lesions like a tuberculum sella meningioma, which can cause an asymmetric defect. So the chiasmal compression can present in many ways. If the tumor is very, very large, that it goes, or there is an aneurysm which presses from the lateral part aspects of the chiasma, you may end up with nasal defects, so which may mimic a glaucoma. So frequent field loss patterns are superior arcuate visual field defect also in post-fixed chiasmas. And this is a patient with a Rathke's cleft cyst, where there is a bilateral, incomplete, partial temporal field defects in both the eyes. More so in the right than in the left. And then here again, there is a change as time goes by. And this here, you can see that in one eye, the patient had a isolated homonymous hemianopia, and because again here it seemed to follow, it was a prefixed chiasma. So this is one of our patients with a chiasmal glioma, and there is you can see there is some kind of a respect of the vertical midline, which you can see that the bitemporal affection is there, but then it is extending on to the nasal half also. And naturally, you just have to follow up these patients of chiasmal glioma, and let's hope that they don't get worse. Now, coming to the retrochiasmal lesions, you have a contralateral homonymous hemianopia, which is incongruous anteriorly, whether it is in the parietal lobe or the temporal lobe, because the thing is spread around. And then as you go posterior, it becomes more and more congruous as the fibers get more compact in the occipital region. The optic tract, the lateral geniculate body, the optic radiation, the visual cortex may be involved. And here then you can see that there is, if you have an optic tract lesion, or the optic tract syndrome is that you have a contralateral homonymous hemianopia. It could be incongruous anteriorly and posteriorly more congruous, as I said. And the characteristic optic atrophy that you see because of this is a bow tie optic atrophy. The pupil is hemianopic. That is, if you project the light from the field that is absent, the patient will have dilatation. But if you project the light from the other field, there is constriction. So the etiology could be either aneurysms, or it could be inflammations or ischemic. Then in the lateral geniculate body, there is a contralateral congruous homonymous quadrantenopia or a sectionopia. There could be a sectorial optic atrophy in these patients, and you can have an hourglass shaped visual field defect. It could be due to a vascular occlusion, AV malformations, or posterior choroidal artery infarction. So when the optic radiation is involved, since it is the longest and most vulnerable, it could be involved in patients who have a stroke. It could be involved in patients who have a hemorrhage, which could be compressing. So you can have it have different kinds of pictures depending on which area is involved. So if it is the anterior radiation which is involved, like in the anterior internal capsule, mid portion, if it is in the temporal lobe, posterior radiation, part of the optic radiation is involved, the thing is in the parietal lobe. So what I forgot to actually mention was that as the optic nerve emerges, there is a 90-degree turn of the optic nerve fibers. But when it reaches the optic radiation, that there is a correction of this 90-degree rotation. So when the internal capsule is involved, you have a contralateral complete homonymous hemianopia, and it would be associated with stroke-like symptoms of hemiparesis, etc. Then if it is when the optic radiation is involved in, like in the temporal lobe tumors, you have the visual field defect that you get is an ipsilateral supranasal and a contralateral supratemporal field defect. The ipsilateral infratemporal fibers and the contralateral infranasal fibers are involved. The inferior fibers course anteriorly and forming the Myers loop, where for 2.5 centimeters from the anterior tip, and the inferior macular fibers don't get spared in anterior lesions. Homonymous hemi or quadrantinopic dense in the upper meridian, and these field defects could be peripheral or mid-peripheral, leading to this concept of pie in the sky. The denser fields superiorly in extensive temporal lesions, and so they could be congruous or incongruous. If incongruous, nasal field on the side of the lesion is dense. So coming to the parietal lobe involvement, which is more often vascular rather than with tumors. Here, the typical lesion is homonymous hemianopia, ipsilateral supratemporal and contralateral supranasal fibers are involved, leading to an ipsilateral infranasal and a contralateral infratemporal field defect. It is more dense in the lower quadrant, pie on the floor, usually congruous but incomplete. And here the OKN is the optokinetic nystagmus is dampened when stimuli is moved in the direction of the diseased parietal lobe. So this patient had a right parietal lobe lesion and has a left inferior homonymous field defect, more dense inferiorly. When it comes to the visual cortex lesion, the occipital lobe lesions, you have the vascular, traumatic, or tumors in which are generally affecting here. And the tip of the central homonymous hemianopia can be there, and this leads to a congruous defect. There is macular sparing, at least 5 degrees of sparing is there, luckily. That's how beautiful the God's creation is. And here the OKN is normal. The posterior cerebral artery supplies the mid-peripheral and peripheral field. And the PCA plus middle CA supplies the macular visual cortex. So here you can see in this patient that on the right side, the sparing cannot really be appreciated, but on the left side, the macular sparing can be appreciated. Now, when you can also have unilateral extensive loss or a contralateral temporal hemianopia. You can have, this is another patient of ours who had a meningioma with orbital extension. The right eye had a vision of 612 with an extensive loss and did not give really a reliable field. The left eye was normal, and there were 3 to 4 quadrants involving with the macular sparing and splitting. So there are different clinical entities can have different field effects, and it's interesting to try and correlate between what you see on the MRI and what you see on the field effect. And then, of course, this is something in which this is one field in which we don't really treat. It's the neurosurgeon or the neurologist who are treating. We are just giving them this feedback. So it depends on how involved your neurosurgeon wants to be with the vision, and then it depends on how, because if they don't send the patient to us, we will not end up having or capturing these field effects at the correct time. So you can sometimes have a patient where it appears like it's a advanced glaucomatous loss in both eye, but when you may have there is a superior arcuate scotoma both eyes and inferior arcuate scotoma, and there is sparing of central field effect because of a neuro-ophthalmological lesion rather than the problem itself. Here, this was a glioma of Pons. So you have different cases. Shall I give these cases or shall I call it a day? Aap bataiye. If we are enjoying it, then I can continue with some of my cases.
I think, ma'am, we can go ahead with another 5 to 10 minutes more. I think we have time till 8:30.
Okay, fine. Yeah. Fine. So in this patient, there was very early.
Just there's one question, ma'am. Like, can arcuate visual field defects in optic neuritis mimic glaucoma, and what clinical clues would help us to differentiate between the two? That's a question somebody has put in the chat box.
I'd like the PGs to answer first.
This is actually put by a PG. I think Geetika has put this question.
Okay.
So it comes back to you, Geetika. What do you think? Like, can we have these arcuate defects in optic neuritis, and how do we differentiate? Or Mani, would you like to take up this?
So tell me, is the color vision affected in glaucoma? How often is the pupil affected in glaucoma? How is the clinical picture? What is the optic nerve head look like?
So Geetika, are you there?
What is the eye pressure? And what is the history that the patient is giving? So all these features would help you differentiate between whether it's a glaucoma or not a glaucoma. Or it is are you there? So if it is a patient of glaucoma, you will have some inkling that it is glaucoma by looking at the optic nerve head, by seeing the color vision, by seeing the eye pressure, and all these things will help you differentiate it from an arcuate defect because of optic neuritis. Does that satisfy?
You can speak up, Geetika. There's no need to type, and you can even switch on your camera. That's okay. Yeah, ma'am, we can move forward. Yeah.
Okay, fine. Any other question? You're most welcome to ask anytime. So this is another patient of ours who had very few early scotomas in the arcuate area and a peripheral constriction, marked peripheral constriction of field. And then when we did on the MRI, it was a CP angle meningioma. So sometimes it is good to always be able to have a good reading. Many a times, especially in Delhi, I come across you have an MRI done, but the reporting is not at all good. And or the cuts which have been taken are not really representative. So there is a lot of between the cup and the lip when the imaging comes. And we should ensure that we are able to interpret it properly. Even if we need to ask the radiologist to reassess, we should ask them to reassess the MRIs which are there. So coming to this patient who had a right homonymous hemianopia, the vision was normal. There was a large intraaxial lesion, a glioblastoma, which was involving the left temporal and occipital lobe associated with edema. And this is the picture that the patient had. And the patient came to us twice. This is another patient who had a paracentral scotoma in the right eye, more so nasally. And in the left eye, the patient had advanced field defect, but was sparing the central field. This looks more like a clover pattern, but that the patient actually had a suprasellar cyst, which was a very, very large cyst. And it was causing compression of the third ventricle, causing dilatation of both the lateral ventricles. So here the effect that we had was a combination of not only, so what we call as here probably it's peripheral constriction of visual fields, which is happening courtesy the compression of the lateral field defects rather than of the ventricles rather than the mass affecting the chiasma. So if we get a lot of patients in Cochin, actually this was beautiful because the patients were sent to us again and again, and we could evaluate, and we have had wonderful follow-up for these patients. So this patient came with a recurrent visual loss in the left eye. So we didn't know whether it was advanced glaucoma, and the patient had a right eye nasal scotoma. Later, the patient had come to us to rule out ethambutol toxicity. Patient had tubercular meningitis, was being treated for that. So we didn't know where to fit in this picture. But the patient had such a lot of, so there was a tubercular encephalitis and there was a hyperintensity. But so this was, we stopped the ethambutol, and then the patient took some other treatment for the brain TB, and but the patient's vision did not, the patients, they continued to have problems. The patient actually had even thickened optic nerves conveying optic neuritis. And later when in years to come, we found that the patient also had MS. So sometimes it can be quite a combination of different things. And so we can just try to do our best in a certain situation. We know ethambutol toxicity generally presents as a central scotoma, or there could be a peripheral isoptric constriction. There could be an altitudinal field defect, very rarely a bitemporal field defect. And of course, these patients will have decreased vision, color vision will be affected. And we need to keep all these things in mind. If we are suspecting ethambutol toxicity, it is better to stop the medication. And if there are most times it does not reverse, which is a sad thing. It's sometimes very sad to come across patients to see that how long they have been on this medication, and somebody started it, but nobody told them when to stop it. Or patients are so thin and lean, and it is not being taken into account as to what their weight is. So these patients end up more often with these problems. So with the toxicity. So here the patient has a thickened optic nerve, and so probably optic neuritis. So in nutshell, visual fields are helpful in diagnosis, progression, regression, on follow-up, whether it is with or without treatment. And one can see response of treatment, especially in patients like who cannot undergo a CT where because of the expense, or in patients who are pregnant or in children, they may cooperate with this more easily. So we should do visual field testing in any case of unexplained visual loss, whether even when they have eye movement disorders, diplopia, proptosis, visual hallucinations. Very often patients who have thyroid orbitopathy, they can have visual field affection. I forgot to somehow that slide I missed. So, and you have huge proptosis bilateral, they have field defects. There could be a compressive optic neuropathy. You treat them with a combination of radiotherapy with steroids, and they beautifully improve. So patients with intermittent visual field loss associated with an anterior cerebral artery aneurysm, you may end up again having a field defect. You can have bitemporal field loss in aneurysms. So cause of visual field defect requires both technical expertise and detailed knowledge of the visual pathway, anatomy, including the vascular supply, the neurophysiology, neuropathology, of course, the patient's history, and the full clinical picture and evaluation. That is the patient's vision, the color vision, the eye pressure, the fundus picture, the field effect, the OCT picture, the VEP, and VEP becomes especially important in very little children. And that's how we try to solve the puzzle of patients of neuro-ophthalmology. Thank you. And these are I thank my patients who cooperated and did their field examination. A big thank you to all of you. I'll stop sharing now. Any questions, please?
Geetika and Mani, like, do you have any questions?
Can somebody do the stop sharing for me? I don't know why it's not.
Ma'am, you need to ask 2 questions for the quiz so that we can distribute the prizes. And the one who is going to type the answer first gets the prize. So you don't have to speak up, but type the answer in the chat box.
Okay, it has to be a. Who are the PGs? Can they just say hello to me? Geetika and
Mani. I think there are 2 PGs. Yeah, Geetika is just typing on the chat box.
Yeah, I can see Geetika's thing frozen, and Mani is also there. Okay, great. So a quick question. In temporal lobe defect, what is the type of field defect which you will get in the early stages?
Should I start the timer?
So I'll repeat. In temporal lobe problems, what is the earliest field defect? So
Akshika says pie in the sky.
Okay, right answer.
So that's the correct answer. So 1 prize goes to Akshika. So we can have second question, ma'am.
Mayors, okay, no, I think I should change. It's more difficult to ask questions. After going through the whole damn thing. So AION classically presents with what kind of field defect?
So if you're suspecting an AION, what kind of classical field defect you would look for in the visual field is the question.
Yeah.
So Bharti Ahuja says it's inferior altitudinal.
Fine.
Fine. So we get the 2 winners of this, and thank you, ma'am, for taking this masterclass on visual field defects in the neuro-ophthalmology in an effort to localize the lesion. And I think it is well taken. We appreciate your efforts, and all the fields and neuro-ophthalmic diseases were covered, I think, over a huge variety of cases. What do you say, Rishi, sir? I think ma'am has covered almost all variety of neuro-ophthalmic defects. with examples.
So, very tough topic to, and you made it very simple and easy for the PGs to understand.
Yeah, thank you, ma'am. Thank you very much. And with this, we end this session of Kaksha, and we'll see you back in the next session of Kaksha soon. Thank you, ma'am.
So much, Ankur. Thank you, Dr. Rishi. And thank you, PGs.
And thank you, everyone, for being with us, attending this session on this Zoom. And I know there may be a lot of people who would be on the YouTube, but thank you, everyone.
Yeah. Thank you so much. Bye-bye.
Bye.